why haven't we cured IBD yet, and why can't we do it with diet? Because this is one of the most common questions we get asked. Now, when I see new patients in clinic, which is every day I'm in clinic, I see a patient who comes to me for the first time. I usually ask them, why did you get IBD? And they usually look at me and say, that's what you're supposed to tell me. But everyone has a theory, right? I bet the people here who have IBD and their loved ones who are sitting in the room might have their own theory about why this happened to them. Most people who get IBD have no family history, and they have no idea what happened to them or why this occurred. And so it's a challenge to understand it. Many people will say that they think it was because of something they ate or their diet in some way. And when that's not the answer they give, it's often about stress, right? I was going through a stressful time in school, or she had that really awful job, or he married somebody, well, maybe we won't say that. But you get the idea that there are different things people think about all the time, and it's very complicated to figure this out. And the challenge to understanding why somebody got IBD doesn't necessarily change what we can do to treat it right now, but it does give us ideas about how we might find a cure for these conditions. Because one of these days, something somebody says is going to be a clue that will get us down the right path. So we talk about goals when we manage people with inflammatory bowel disease. The first goal, of course, is to make sure the diagnosis is accurate. And that may sound obvious because most of you here already know you have it. But we have to be careful that we understand not just if it's Crohn's or ulcerative colitis, but really which part of the bowel is involved, why do the patients have symptoms that they experience, and what about all the things outside of the bowel that sometimes give people problems. And once we've clarified that, we start with something called inducing remission. We borrowed the term remission from our cancer colleagues, but we use it in inflammatory conditions too. And the concept of inducing remission means we turn off the inflammation, because that's what IBD is. It's an overactive immune system of the intestines. So we want to turn it off so the patient feels well, and we also want the result of that to be normal labs and normal growth and development or restoration of those things if they've been delayed in some way. And we want to do it as fast as possible. Once we've successfully induced remission, we talk about our second main goal. Our second main goal is called maintenance. So this is the concept of preventing a relapse or progression of the disease over time. And it acknowledges the fact that most IBD is chronic. And a chronic condition has a tendency to come back. A chronic condition has a tendency to want to push back when you treat it, and therefore we want to do our best job to prevent that from happening. So how do we do that? Well, we talk about making sure that the disease is stable. So what we don't want to hear is that every 2 weeks you have 2 days where you feel terrible and then you're okay again. That's not really stable control. And we don't want to hear that, yeah, I'm fine for 9 months out of the year, but during the winter I'm terrible. That's also not stable control. But we also recognize that if we do this the right way, and now we can prove it, we're able to change the natural history of the disease. That means that we can prevent outcomes that we don't want. What are those outcomes? Hospitalization, surgery, repeat surgery if you have Crohn's disease, disability, missing school and work, all those things that we like to avoid. We've learned that if we can actually get people into a stable maintenance phase for their condition, we're likely to avoid those and to do a better job. And the last part of our management strategy, the main goal, is what we call disease monitoring and prevention of other complications. What does that mean? Well, this is a relatively new concept. Think about IBD the way we might think about diabetes. You know, people who have diabetes check their blood sugar on a regular basis, they adjust their diet, they adjust their insulin, and they try to keep themselves within some level of control. In IBD, we've now gotten to a point where we can do the same thing. We can monitor the disease to know when it might relapse before the patient even feels that they're going to have a flare. So if we can just be ahead of the game, we can actually do a lot better. We also, of course, want to monitor the therapies people are on. I know that patients are nervous about being on some of the treatments we use, and it's very important that we monitor them while they're on it. And then, of course, we want to prevent things. We'd like to prevent cancer, which we're good at doing now. We've actually seen cancer rates in IBD drop significantly in the last number of years. That's good news for you all. And we want to prevent infections and other complications from the disease. So when you think about your inflammatory bowel disease or that of the one you love who you're here representing or with, I want you to think about where are you in the spectrum of our different goals. Are you still in the place where your disease never really got induced into successful remission? Or are you in a maintenance phase right now, but you're wondering if you're going to flare tomorrow? And that means you probably aren't in the monitoring phase where we're doing a good job preventing that from happening. So this is how we now think about inflammatory bowel disease.